able to sensitize ourselves about a condition that we are all familiar with. But we just want to raise awareness, point our attention to some important things so that we can manage our patients better and we can all improve in the treatment of our patients. And today, I'm not alone. So Dr. Mariam Abdulkadir is with me, so we'll be presenting together. So Dr. Mariam, welcome to Cardiocare webinar.
Thank you very much. Good afternoon, everybody.
So I think you will enjoy. I think this is the first time you are joining.
Yes, my first webinar. So
you'll be seeing more of our faces more in subsequent webinar. So we'll be sharing from our wealth of experience.
Knowledge.
And knowledge. So we have about 64 people already. So I think it's a good time to start so that we will have enough time to discuss. You can always put your question in the Q&A or the chats, and we'll address them as we continue. Then to remind us, we're coming to you from Cardiocare Multispecialty Hospital, a member of the Limi Hospital Group. We do this webinar every month to sensitize us about topic in internal medicine generally. And today we are talking about heart failure in primary care. We want to see how we can recognize heart failure right down at the primary care level, from the local hospital, from the local government health center, at least the basic sign and symptoms that we can pick that will aid a quick diagnosis of heart failure. Because we've seen that in many cases, by the time patient gets to the tertiary level,
it's already very bad.
Very bad. A lot of misdiagnosis, a lot of treatments that made the whole scenario more complex and more difficult. So that's why we felt we should just come and talk about the typical presentation of patient with heart failure. And we'll be starting with a case presentation. So Dr. Mariam.
So our case presentation is a 48-year-old businessman. He presented to our facility with complaints of dyspnea on exertion and easy fatigability for 3 months. There was also cough and orthopnea, as well as PND. And he had palpitations, leg swelling, and no chest pain. The cough was productive of sputum, and he had about 2 episodes of hemoptysis prior to presentation. He also had abdominal distension and abdominal pain around the umbilical region. Pertinent history is that he was not a known hypertensive, diabetic, or asthmatic, but he had a chronic history of alcohol use. He would take about 3 bottles a day, take palm wine and gin for over 12 years, but he recently stopped 2 months prior to presentation. And we typically see that a lot, actually. They will stop once they start feeling those difficulties, those symptoms. He also smoked 5 to 10 sticks for over 7 years and stopped also 2 months ago prior to coming to the facility. And he also used to take herbal preparations, and he smoked marijuana. So on account of the cough and a history of body weakness, he went to the hospital and he was treated for pneumonia and malaria. The weakness was relieved, but he continued to feel that dyspnea on exertion and generalized body weakness a bit. So he went back to the hospital and they requested a chest x-ray, and the chest x-ray showed cardiomegaly. So he was given digoxin and then referred to us for expert management.
Thank you for that presentation. And as we continue in the presentation, we will know why we have brought this case. Is one of the many cases we have managed successfully here. And from the history, we'll see that the complaint, the symptoms he had were non-specific.
Yes.
They could mean a lot of things. And that is the first thing we want to point out in this presentation of heart failure, that many of the symptoms that we will see in patients with heart failure,
we see them in other conditions.
we see them in so many conditions. Like for him now, he was treated for malaria,
pneumonia,
and pneumonia. And it was because it didn't get better. That was why somebody felt, oh, let's check something. Let's do a chest X-ray. So assuming the chest X-ray was done ab initio, somebody would have seen the cardiomegaly and would have known that this is not just malaria and the chest and the pneumonia alone. So most of the symptoms we will see in patients with heart failure will come like this. So somebody can be coughing, which could it be asthma, could it be pneumonia, could it be
regular acute respiratory tract infection.
But we need to look at the whole context of the patient before we decide what to do. And when the cardiomegaly was even picked, it was started on digoxin and then referred. So we'll know as we continue whether the digoxin is the appropriate method of treatment to have been offered for this one. But the good thing about this patient was within 6 months of commencing treatments, it improved remarkably. Remarkably. I think we still have this examination point.
Yes, so on physical examination, we met a middle-aged man. He was not pale, anicteric, acidiagnosed, afebrile as well, with pedal edema. His cardiovascular profile showed a pulse rate of 112 beats per minute. It was moderate volume and regular. His blood pressure was elevated, 170/131, and the JVP was elevated. Also, his apex beat was displaced at the sixth left intercostal space, lateral to the mid-clavicular line. Listening to his heart sounds, there was S1, S2, S3, obvious tachycardia. And then on chest examination, he was tachypnic, respiratory rate of 28 cycles per minute. The oxygen saturation was 98% in room air. And on auscultation and examination, he had fine bibasal crepitations alone. Abdominal examination showed an enlarged liver. So the liver was 16 centimeters below the right costal margin. It was non-tender and other organs were non-contributory. So investigations that were done, we did a BMP, which was elevated. He had a normal kidney and liver function test. A full blood count was also normal. And on doing his echo, we noted that his left ventricular ejection fraction was between 20 to 25%, and he had eccentric hypertrophy.
So at least at our level, we had the opportunity of doing some of this extra investigation, but from the history and examination, that's where we want to really focus on today, so that we'll be able to pick the important symptoms, the important sign that is needed to aid the diagnosis. And whatever investigation, even if it's just chest X-ray, if it is an ECG we can do at our level, we can put everything together, and that can help us to make our assessment, at least make a provisional diagnosis that this patient is likely or could be having heart failure, because that is going to help us in, okay, do I give this patient a lot of fluid? Do I give this patient some type of medication? And before we even send to the next level of care. And so that's the main reason for this presentation. And as we go on, we'll be making reference to this case. I'll be pointing out things that could have been done better or things that were appropriately done. And so we'll start. What do we call heart failure? What do we say when we say a patient has heart failure? And it's a syndrome that is made up of symptoms and signs that is suggestive of either a structural or a functional abnormality of the heart. Then, in addition to other evidences, whether you have evidence of a raised natriuretic peptide level, or you have other investigation that showed evidence of pulmonary or systemic congestion. That means you have symptoms suggestive of heart failure, signs suggestive of heart failure, plus either maybe an echo finding that shows you the EF, elevate abnormality in the feeling prayer of the heart, or you have other tests or BNP that is elevated. So you need your symptoms, you need your examination to pick up pertinent sign, then you can now add other things to it. Then to just simplify it, we say heart failure is when the heart is not able to perform its function. And what is the function of the heart? Is to be able to supply the needed blood or oxygen for the metabolic need of the tissues in the body. And when it is not able to do that, you now see all or some of these features. Patients become dyspneic, there's fatigue, you see sign of congestion, whether systemic congestion or pulmonary congestion. And it's a condition that is characterized with frequent hospitalization, a shortened life expectancy, and the quality of life for patients with heart failure is usually poor. And it's a final common pathway for many conditions. Unfortunately, heart failure, hypertension, diabetes, cardiomyopathy, even some people on medications, cancer therapy, some of them, what will eventually lead to their demise is heart failure. So we have different definition, but simply put, like I said, is when the heart is not able to perform its function, whether due to a problem in the function or the structure of the heart. You have the signs and symptoms, and you have other evidences. If they are available for you, you can do your BNP, or you have the opportunity to do an echo. So, and then, like we say, it's dead there.
Unfortunately, yes. So the 5-year death rate of heart failure is higher than that of leukemia, higher than that of lymphoma, higher than that of colon or rectum cancer and the breast cancer.
And in 5 years, almost 50% of patients with heart failure will die within 5 years. And that's worse than all cancers put together. So the same way we look at patients with cancer, it's the same way we should pay attention to patients with heart failure, because if not well managed, like I said, within 5 years, 50% of patients will die from this condition. And like we see from this chart, is a progressive condition. So we have period when the patient is actually asymptomatic, like we will discuss when we're talking about the classification and the staging, but the risk factors are there.
Yes.
But at that point, patient is not showing any structural changes in the heart. Patient is not showing any symptom. Then later it progresses to a stage when you have structural changes in the heart, but the patient is still asymptomatic. Then now you now enter a period where there are symptoms, and gradually,
and usually with that, functional changes in the heart have already set in.
Worsening of symptoms up to the point that the patient gets to an advanced stage where you will need some other advanced form of treatment to be able to help the patient. And so talking about the epidemiology. So Dr. Mariam.
Okay, so etiology when it comes to heart failure, survey of heart failure shows that hypertension causes almost half of, is one of the predecessors to almost half of the cases of heart failure. We also have conditions such as dilated cardiomyopathy, which covers almost 20%. And for us here at Cardio Care Hospital, I think most of our cases, I can say more than 50 or 60%, hypertension is the main predecessor to heart failure. So that will constitute poorly controlled blood pressure, but also for those who are well controlled over time.
Some people don't even know
that
they have hypertension until they start having the symptoms and signs of heart failure. And maybe because we have a cath lab, we're seeing a lot of ischemic disease, and we're seeing a lot of them with heart failure, even from presentation. So coronary artery disease is gradually even coming up above cardiomyopathy, and we should not forget that we can also have ischemic cardiomyopathy from coronary artery disease. So between cardiomyopathy and coronary artery disease, they are really competing for that second.
I think for us, we have that coronary artery disease.
And the study has shown that heart failure prevalence is increasing and will keep increasing because one, we are having more aged people. Then because of the improvement in the treatment of ischemic heart disease, coronary artery disease, we are now seeing more people surviving heart attack. And like I said, one of the complications that we have occur after heart attack is heart failure. Then like we talked about hypertension as the underlying cause, most of the underlying cause, the prevalence are also on the rise. Hypertension, diabetes, coronary artery disease, obesity. So when you put all this together, it means that we're going to be having more patients with heart failure. Then we should also forget the use of illicit drug in the young has been also on the rise because like the case we presented, it was doing a lot of alcohol, it was doing a lot of marijuana and all those stuff along the line. Then availability of effective drug is also helping us to prolong the life of patients with heart failure. So in the past, when there was no Uperio, no SGLT2 inhibitor, so we have all those effective drugs. I was talking to one of my patients' relative yesterday, and the person was asking, "Oh, do you have Entresto? Do you have a pagliflozin?" I said, "We have all those ones now." But before, those drugs were not available. So, but now we have all those effective drugs, and that is improving the survival of most of our patients. So, and then another reason why we felt we should bring this up is that this is a study done in Italy, in Europe, talking about the knowledge of the general practitioner about heart failure. You know, like we said, one, the symptoms are not specific. So it could mean a lot of things. So the difficulty is there for people to really understand, as in be able to identify. So up to 80% of patients with heart failure were mixed in that because the population they have, aged population that came down with heart failure, these same people, patients, some of them had COPD, some of them are diabetic. So it was difficult to see, okay, these symptoms, this cough, this dyspnea, is it heart failure? Is it COPD? So many of heart failure in this series were missed. But at the same time, there were also about 70% of patients that were incorrectly diagnosed to have heart failure, but they ended up having COPD, some just chest infection. So the difficulty or the challenge in making the diagnosis is not just a Nigerian thing, it is everywhere because there are a lot of these symptoms that are not specific. People cough from different, but by the time, like we said, the most important thing is to look carefully, look at the symptoms, look at the signs, then look at all the predisposing factor or underlying cause that will bring heart failure high on the list, and we can now send for under investigation to confirm our diagnosis. So, and in a general practitioner setting, what we want to do is the aim is to be able to identify patients as early as possible. Because from our definition, I talked about heart failure being a progressive condition. But if we make the diagnosis early, that progression, we can prolong that progression and improve patients' survival. So it starts from identifying patients that are at risk for developing heart failure and preventing them from having heart failure. So patients with diabetes, patients with hypertension, obese patients, patients with hyperlipidemia, these are patients that we have to look at extra, monitor their blood pressure, control all those factors, and institute medication that even at that early stage will help. So patients with diabetes, as you're controlling the sugar, the patient should also be on an SGLT2 inhibitor if you have, then control all other things and monitor them closely. So that once you start noticing any, so you have a patient with hypertension, diabetes, start having leg swelling, start having undue fatigue, undue tiredness, then you have to quickly look at that patient. Let me send you for ECG. Let me send you for a chest X-ray to be able to quickly diagnose what the problem is. And by the time you make this diagnosis, you will be able to institute your treatment very early before the patient gets to the advanced stage of the heart failure. You will know the appropriate time to send the patient to the next level for care. So that's the disease trajectory. It's when we miss the prevention stage, sometimes we miss the diagnosis stage, then what we have is patients coming to the tertiary care with advanced heart failure. By then, it is too late. A lot of damage has been done. So let's go to the possible causes of heart failure.
So some etiology of heart failure. So I'll mention, you can see them right on the screen. Valvular heart disease, as we spoke about, mitral, aortic, tricuspid, or pulmonary. We have pericardial diseases such as constrictive pericarditis. I think we have 2 or 3 patients that I can recall now that came in with such symptoms and then developed heart failure. We also have high output states. So for example, anemia, sepsis, thyrotoxicosis, which is why thyroid function test is one of the key things in diagnosing heart failure. Then we have volume overload. So renal failure, it could be iatrogenic post-operative fluid infusion. You know, patient post-surgery got a lot of fluid and then had already risk factors for developing heart failure, suddenly tipped into heart failure. Then we have congenital heart diseases. We also have arrhythmias, tachyarrhythmias, ventricular arrhythmias, bradyarrhythmias, and conduction disorders such as atrioventricular block. We have endocardial diseases with or without hypereosinophilia. And then we have myocardial disease. I think that's really our main focus here, the myocardial diseases, coronary artery disease, hypertension, and cardiomyopathy.
Myocarditis is also there. Because here, there is always a reason for the heart to fail. Because if we don't look at that cause and you are just giving furosemide and digoxin, the patient will not get better. So you have to identify what led to the heart failure. So we have to identify that, and that is why as we're taking the history of the patient, we are not just looking for just leg swelling, shortness of breath, fatigue, difficulty with breathing while lying down. Part of what we're going to find in the history is to look for all these causes. In this environment, hypertension is number 1, like we said. So the history of hypertension, history, whether the patient has been taking BP medication before, we need to find out that, then look out for other causes. Here, we said hypertension,
was the etiology,
ischemic heart disease, cardiomyopathy. We have to take history about drug use. We have to take history about alcohol use, because those are the things that are common in our environment, but it's good for us to know everything. So we have etiology, then we have what we call precipitants. Because after the patient develops heart failure, the patient may even be stable and be coping. But something will now tilt the heart and put that heart on the downward trend and on the slope to decompensation. So many of the things we have on this board can also be a precipitant, but we'll talk about these ones as we continue in this journey. And irrespective of what the cause is, what happens is there's injury to the cells of the heart, that is the myocytes. And once that occurs, there are a lot of changes that happen in the heart, which we call remodeling. There are some changes happen right from the length, the shape of the cell, the length of the cells, the arrangement of the cells. All these are disrupted. And when this happens, there are a lot of things that are sensitized. There are a lot of things that are triggered because of these changes. You have a lot of neurohormonal changes from the renal angiotensin, aldosterone axis. You have sympathetic stimulation. So all these things, when they work together, you have some causing vasoconstriction, some causing fluid retention, sodium and fluid retention, some causing fibrosis in the myocardium, damage to the. So at the end of the day, you end up with ventricular remodeling. The heart that is normally should be elliptical in shape now become like a sphere, and it becomes dilated. So you have all these changes, and if you don't break any of this cycle with the treatment that we have now, the patient will continue to get worse. The EF will reduce, the supply to the kidney will reduce, there will be stimulation of the renin-angiotensin system, all those also lead to stimulation of the sympathetic nervous system. So you have a lot of things going on at the same time, making the heart to get worse. So the aim of what we want to do is, after identifying all these symptoms, each of our treatment is aimed at cutting one of these legs so that the patient can get better. And that may not be easy for you to do all these things, but once you identify the patient and make the appropriate diagnosis, you can always send the patient to the next step. So to the meat of the presentation, we have said most of these symptoms are not specific. Yes. So how do we recognize? How do we diagnose heart failure at the lowest level? And that's why we said it starts from the history. We want to take the history of the symptoms. Like I said, we want to look at what the underlying cause is. We want to identify the precipitants. That is the most important. So patient comes to you complaining of fatigue, because I said the heart is not able to supply enough blood to the tissue, to the muscle. So the patient gets tired. Somebody that can walk from Federal Secretariat to where now? To Barnett before.
Can't do that. Can't climb the staircase.
Now finding it difficult to climb from first floor to the second floor. Then started having shortness of breath, which we start with normal activity, then later progress to shortness at rest. Then
shortness doing day-to-day activities.
Cough, productive of sputum. Sputum is frothy. Sometimes it could be pinkish. Then
sometimes also dry.
Then patients are complaining of swelling, leg swelling, and all those things like that. So you'll be suspecting, oh, what could this be? Because all these symptoms we talked about could mean a lot of things. Leg swelling, patients with renal kidney failure can have leg swelling. Patients with chronic liver disease can have leg swelling. Patients with malnutrition can have leg swelling. Patients with deep venous thrombosis can have leg swelling. So, but that's why I said you put things together and you say, okay, this patient has leg swelling,
dyspnea and exertion,
difficulty with breathing, cough, has history of hypertension. You can say, oh, this is pointing towards, could it be the heart, could it be the kidney? You know, from those four, it's likely going to be the liver. So, and by the time you add your examination finding to it, you will narrow down and you'll be able to code down. So history, examination, and with the investigation that is available to us, at least I know, at least we'll be able to do a chest X-ray and at least do an ECG. So that can help us to confirm the diagnosis. That can help us to identify other risk factor or other diagnoses, because a patient has fever, a patient has cough with difficulty in breathing. You can do the chest X-ray and see findings suggestive of pneumonia. So you can say, okay, oh, this patient has a pneumonia. You start your antibiotics and the patient gets better. But at the same time, like we said, that same pneumonia could be a precipitant for heart failure in the patient like that. So it needs a lot of careful history taking, examination, then with the help of the investigation that is available to us. So the symptoms, again, let's just go through them again.
So some clinical symptoms, I think the one we come across the most at our facility is that dyspnea. That's level of exertion, being unable to do their daily-to-day climbing up the staircase, going to the market without feeling this heaviness in the chest. That's one. Orthopnea also, lying down, and then they complain that they have difficulty in breathing. PND, so which is basically, you know, they use a lot of pillows and then they wake up in the night breathless. So once you have those three things, I think that's more of the chest findings when it comes to patient symptoms in heart failure.
And
another thing is
let me quickly add to that, that orthopnea and paroxysmal nocturnal dyspnea, they are highly specific to heart failure. They are not that sensitive. Most patients may not have it, but for patients that present with orthopnea, I mean, once they try to lie down, there is a shortness of breath. So they keep increasing the number of pillows. So you just ask, oh, please, how many pillows do you use when you are sleeping? You say, initially I was using one, but later I used to feel uncomfortable, so I need to use two, I need to use three. Some people have to sleep sitting up because of the level of difficulty with breathing while lying down. So that is a very important history. And like she said, the paroxysmal nocturnal dyspnea, they have to wake up suddenly at night from sleep, looking for breath. So those two, they are very specific. The dyspnea is very sensitive. A lot of patients will have it, but less specific for heart failure. Like I said, patients with asthma can have dyspnea. Patients with chronic obstructive airway disease can have dyspnea, and from other conditions too. So, but orthopnea, PND, so it is important to ask, oh, you have shortness of breath. Okay. Are you comfortable lying down? Flat. So not really. How many pillows do you use? So, like the patient we presented was using 2 to 3 pillows to sleep every night before he was identified to be having heart failure. We talked about cough, frothy sputum, but sometimes the cough may be unproductive. The edema, swelling of the leg is not specific. It could be from other conditions, but like we know, edema from heart failure is dependent, starts from the lower limb, is usually bilateral. When you have a patient with unilateral edema with associated pain in that leg, please think first of a deep venous thrombosis before you think of heart failure. And we said fatigue, they are fatigued because
the heart function is not
adequate, so the tissues are not getting enough oxygen. So they usually complain of fatigue, which is common to, it could be malaria, it could be
constitutional symptoms, so it could be anything.
And when you examine them, the important thing you want to look for, still check for the edema, but you want to check for crepitations, and you want to look for jugular venous distension and the third heart sound. These ones are more specific for heart failure, and for people that knows about Framingham criteria, these are the major criteria that you really need. But we want people to be able to identify the symptoms. Then when you check the patients, depending on how the level of the patient's presentation, you may be able to still pick the edema. When you listen to the lung basis, you hear the crepitations. And when you look at their neck, you can see the distension there. So if those are the things you can pick, or even if it's just the symptoms, then your suspicion should be high that you may be dealing with patients with heart failure. And this is just showing us
edema,
what we talked about. Bilateral pedal edema. For some people, it could be so gross that there's scrotal edema and even edema up to the anterior abdominal wall. But for most people, it is on the lower limb. It is bilateral, like we said. Ideally, it should not be tender. So that you can identify. Then you can see a patient with raised jugular venous pressure. And for people that like stuff, there is some differential diagnosis of raised jugular venous pressure. And this is the picture of someone with orthopnea. You keep raising the number of pillows so that they can be comfortable. But like I said, some people can be so bad that they can only sleep sitting on the chair. Some people cannot even lie down at all because of the degree of the pulmonary congestion they have from their heart failure. So these are important symptoms and signs that we want us to be able to identify and pick up early in our patients. And another thing that I want to add at this point is when we see these things, we should look at what the patient has been doing, because some of these patients would have been on some medications that will even worsen their condition. Mm-hmm. But we'll talk about some of this as we proceed. And so when we identify these symptoms, then you may be, that one will help us to be able to classify our patient into categories that they belong, so that once you make a call that, I'm seeing this patient, and I think it's in New York Arts Association class one, everybody will understand what we're saying. And it is the degree of symptoms that we really use to classify this group of patients, whether there is limitation of activity or where there is no limitation in the level of activity. So for New York Art Association classification, Dr.
For the, as we call the NYHA classification, it's 1, 2, 3, and 4. So it gets progressive as you go along. With NYHA 1, there's no limitation to physical activity. So their normal physical activity doesn't cause them any breathlessness, any fatigue or palpitations. But this patient has already been diagnosed of heart failure in the past. This is just someone that's in a good, stable state. So then we call those NYHA class 1. NYHA class 2, they have slight limitation of physical activity. So they are okay at rest, but once they start doing some physical activity, they develop some breathlessness, some fatigue, but they're able to go ahead with those tasks. When we get to NYHA 3, there's marked limitation of physical activity. So they're still okay at rest, but less than ordinary activity. So for some people, it's as little as putting on their clothes, brushing their teeth, getting their children ready for school. It makes them have undue breathlessness, undue fatigue. And class 4, which is the highest of the classifications, they're unable to do any physical activity without discomfort at all. So those symptoms are also present at rest, something that we need to note. That's what differentiates 3 and 4.
They are uncomfortable even at rest, dyspneic at rest, almost not able to do anything.
You find most of them being restless.
Yes.
Changing positions.
And what we should know about NYHA is with good treatment, patients can move from 4
to 3,
back to 3, back to 2, and possibly back
1
to 1. Then we now have the American Heart Association and the American Cardiology staging, which is a bit similar, but also a little bit different. And for AHA staging, we are from A to D. And this is important because we want to be able to catch patients as early as possible. So for the stage A, these are patients that they don't have any symptoms of heart failure,
but they are at risk.
They don't have any structural change in the heart, but they have risk factors. So patients with hypertension will be here, patients with diabetes will be here, patients with coronary artery disease will be here, patients with family history of heart disease will be here. So these patients are in stage A. So anybody with hypertension is in stage A of American Heart Association stage because of preventive measure that we need to do in them. Then for stage B, they don't have any symptom, but they have evidence of structural changes in the heart. So this patient now has left ventricular hypertrophy. You do their ECG, you do their echo, there's LVH, there is valvular problem. These people, they are in stage B, but they don't have any symptoms. And you can compare those people in stage B to people in stage in NYHA 1. No limitation of activity. So these patients, they are asymptomatic. Then for AHA stage C, now patients have symptoms, either past symptom or present symptom. So once someone has any symptoms of heart failure, that patient is in stage C of AHA, irrespective of the symptoms. Then stage D, that is the advanced stage, where they need advanced care, they need device therapy, they need specialist care. And at that stage, they will be in stage 4 of NYHA. So, but for AHA staging, there's no downgrading.
Yes.
Because like you said, once somebody has symptom, whether past symptom or present symptom, the patient is at least in stage C. And once you are in D, you are in D. But NYHA, you can move down or up, but in AHA, you can only climb the pyramid. And we've already talked about the difficulty in recognizing symptoms because of some other comorbidity that make diagnosis difficult. So these are now the challenges we have. So to be able to distinguish heart failure from COPD, asthma, people with chronic liver disease, people with DVT, and we're mentioning some of them because there's something we call cardiogenic asthma or pulmonary edema that can present like a patient with asthma because of severe elevation in pulmonary capillary wedge pressure from the congestion, and patient presents with wheezing and all of that. But with good history of hypertension, maybe heart failure in the past, you'll be able to identify. And because missing some of these conditions may even worsen the state of the patient, because a patient with asthma that you want to give a beta agonist, a bronchodilator.
You consider if the patient
so if the patient is in heart failure, now you give that, the drugs will increase the heart rate of the patient, will reduce the systolic filling of the heart. The patient is going to get worse. So we need to be able to take a good history. Know that a patient with asthma, maybe childhood history of asthma, has been on the asthma therapy, family history of asthma, but it's difficult seeing a patient for the first time at the age of 55 with difficulty with breathing, cough, and you're thinking that asthma is the number one. COPD, you will find other features, barrel-shaped chest, long-term history of smoking, long-term history of cough, and other associated findings on the chest X-ray. And then the characteristic of the cough that will help you to know that I'm dealing with a COPD and not a heart failure.
That also plays with the chest infection as well.
God bless you. So chest infection, your chest X-ray finding, but like we said, chest infection can also be a precipitant to heart failure. Then you have patients with kidney disease, you have associated facial edema, reduction in urinary output, and other things that will help you. And by the time you check your kidney function, you'll be able to get other information. Chronic liver disease, by the time you check your liver function, the examination, ascites, and other things that may be out of proportions, jaundice, other signs of chronic liver disease. Then we talk about DVT, mostly unilateral swelling with associated pain. And by the time you do your Doppler ultrasound, you'll be able to identify the clots and you'll be able to distinguish what. Sometimes it might actually be difficult. And that is part of the reason why, if you have this difficulty, it's part of the reason why you will need to send your patients to the next level of care where they have the opportunity of doing other investigation, maybe a BMP, an echo that will help. Because like I said, it may actually be a bit difficult sometimes.
So some of these investigations that we typically do or we suggest you do are chest X-ray. So there are some clear-cut findings which we'll go into further on what we'll see with the potential patient with heart failure on chest X-ray. For example, the index patient we spoke about, he had what we call cardiomegaly. So that's one of the signs of heart failure, but there are other causes of a cardiomegaly which we can go into. Another thing that you can do is an ECG. Now, the ECG may not show you heart failure exactly, but it will give you key indications to certain risk factors. As we spoke about earlier, patients with hypertension, you see signs of LVH, patients with dilated cardiomyopathy will have signs in ECG. Then we have echo. Now, echo is not something that is readily available, but it's quite diagnostic, quite key in diagnosing heart failure.
But if I know chest X-ray is readily available, we can have an ECG done. There's no pathognomonic ECG changes that can say, oh, once you find this, it's heart failure. No. But it is very rare for you to find a normal ECG in a patient with heart failure. So you see patients with some of these features and you do the ECG and the ECG is normal, it is less likely to be heart failure. Because for patients with heart failure, you will find something. Even if it is just a sinus tachycardia or a bradycardia, you will find something. Then the ECG may show you some things that may be either underlying cause, maybe atrial fibrillation, could show you arrhythmia, could show you features of coronary artery disease that might point you to what the underlying cause is, or maybe what the precipitant is. But you can do your chest X-ray, you can do your ECG, you can do your full blood counts. Yes. At least if it is infection, you may be able to pick something. If it was a chest infection, you may be able to pick something. If patient has anemia, you can see the PCV. Mm-hmm. So this you can pick. By the time you do your kidney function test, the EUCR, you'll be able to say, oh, this may actually be a chronic kidney disease patient. Your LFT will help you. So at least you can do chest X-ray. We may be able to do ECG, your full blood count, your EUCR, then I think maybe LFT if it is available. So if we can be able to do those basic, it will help you to narrow down that, okay, most likely this is what this patient is likely having. And because we know that echo, BNP, troponin, Doppler ultrasound are not available at our primary care level in Nigeria. So chest X-ray, ECG, full blood count, EUCR, liver function test, and also check your blood sugar too. Yes. It will also help. And by the time you are able to escalate the patient to the next level, they can do the BNP to confirm your diagnosis of heart failure. And like we said, for all those, your chest X-ray will show you cardiomegaly, we exclude other conditions, pneumonia, pleural effusion, and other stuffs like that. And this is at least a chest X-ray of a patient with heart failure. We can see how big the heart is. And what we are measuring is the cardiothoracic ratio, the diameter of the chest wall. Then we're also measuring the diameter of the heart shadow. And you put it over each other. Once it's more than 50%, then there's increased cardiothoracic ratio. So the heart is big. Then you can see this upper lobe diversion. You see the dilated vessels on the upper lobe of the lungs, and the fullness at the hilum. So these are things you can see that can suggest heart failure to you. And apart from that, you can see edema, pleural effusion. Then on the chest X-ray, if you see features suggestive of pneumonia and the heart size is normal, most likely you are just dealing with a chest infection and not heart failure. If you can see features of COPD, you see the narrow mediastinum, you see the hyperinflation of the chest, you are dealing with COPD and not a heart failure. So that will help you. And by the time you get to the tertiary level, you can do echo, you can do strain imaging. So I just put this because this is for the patient we presented. The heart is dilated, the ejection fraction is very low, and the strain pattern was so poor, showing global reduction in the strain for the patient that you can see is diastolic function. But with treatments, this patient came in December last year, and by the time we did the repeat echo this week, a few days ago, it was amazing. His EF improved from 25% to 45% to 50%. It just looked like a miracle to everybody. And the man promised me that the next time he's coming from Cross River, he's going to bring jam for me. So told me the same. That's dividend of good practice. So, but we want us to be able to do a chest X-ray, identify the abnormality there. If you're able to do the ECG and do the basic blood work, it's going to help us to narrow down and to calm down on what the diagnosis or the differential diagnosis is. And if we have the opportunity to be able to do something, we'll start while we send to the higher level for further care. And these are just other things that that is recommended. If it is available, you can do then the thyroid function, the alters, and all the rest. But like I said, the basic thing we want us to be able to do, take a good history, look out for the symptoms,
Signs.
Causes, try to identify what possible causes are, what possible precipitants we can identify, do our examination, pick up the important signs, the pida edema, the crepitations, the raised JVP, the displaced apex beats, the third heart sound, the tender hepatomegaly. We are putting everything together. If you are able to do the chest X-ray, exclude other differential diagnosis, or be able to identify whether patient has chest infection, pulmonary edema, then we can put everything together. Like we said, you have already your symptoms and signs. You have evidence of damage from the chest X-ray. Then we can put our diagnosis together and say we have our diagnosis of heart failure. And if you have the opportunity of doing echo, like I said, we're looking at the ejection fraction, we're looking at chamber sizes, we're looking at diastolic dysfunction. We want to see whether there is wall motion abnormality that can suggest acute coronary syndrome. And if you can do speckle tracking, it helps you to identify what the patient is. And that can help you to classify your patients based on their ejection fraction. We may not be able to do this at the primary care level, but it's good for us to know that your echo can help you to classify your patient based on their ejection fraction. So we have those with reduced ejection fraction. For those group, the ejection fraction is less than 40%. Then you have another group that is between 40 and 50%. That's 41 to 49. That is the group we called heart failure with mildly reduced ejection fraction. Then you have some that their ejection fraction is from 50% and above. That's the one we call the heart failure with preserved ejection fraction. Or some people call them diastolic heart failure. While the one with the reduced ejection fraction, some people call them systolic heart failure. Then the in-between is the mildly reduced ejection fraction. Then they added another one in the recent guideline that if a patient has a reduced ejection fraction before, you treat the patient and the ejection fraction improve, like this our index patient, you can say they now have heart failure with improved ejection fraction. So, but that is for people that have the opportunity of doing echo. So we talked about this algorithm already. What you need to make your assessment: clinical history, examination. You can do your ECG. You can do those basic lab tests. In this environment, you are almost 60% done. At least you can confidently make heart failure your number one on the list. Then, if you can now send to where they can do echo, they can do BNP, then you can now further stratify into different stages based on the ejection fraction. So the next question now is, what are the things you can do for treatment even before you send your patients? Let's go on. Let's go. So the next question is, what do we do? What can you do at your level? And that is why the principle of treatment is there for us to be able to follow. And once we can do this, there are things we can start at our level before we think of sending the patient. So, Dr. Mariam.
So, treating the etiology is, like we said earlier, our number one thing. It can also help in prevention. So if the patient is hypertensive, ensure that they're on the appropriate medication. If they have ischemic heart disease, we have medications such as beta blockers that can aid. Then optimize other cardiovascular risks if they are hypertensive or diabetic or pre-diabetic. If they have hyperlipidemia, ensure that their cholesterol are at optimal level. Then what we can do is to find and treat the precipitant if they present to you in an acute state. So as we mentioned earlier, there are some things that precipitate heart failure. So things like infection. You may have a patient that has diagnosed heart failure and then comes in with symptoms, and then his precipitant was a chest infection. I think that's one of the precipitants we have primarily here. Another is also a patient that was hypertensive and then stopped their medication. It stopped their medication maybe for a few weeks to few months. That can be a precipitant into heart failure. Another thing is also fluid overload and electrolyte derangement.
So continue, let's just look at it. Then treat comorbidities, assess. So when we make our diagnosis, the treatment principle we want to follow is, at least number one, you confirm your diagnosis. And we say in making the diagnosis, you have to look for the underlying cause. You have to identify the precipitants. And by the time you have your symptoms, you'll be able to classify your patient. Okay, my patient has heart failure. Is the New York Heart Association class 2 or class 3. This heart failure was caused by hypertension. Then, after examining and taking my history, the precipitant I find is like he has chest infection. It's like he was taking too much salt. He stopped his BP medication. Those are, and so your treatment is to look at each of those ones. So you want to make him better from his symptoms of the fluid congestion, the edema, the dyspnea. So you have to take care of the symptoms. You have to take care of the underlying cause. You have to look at the precipitants, and you now have to look at other cardiovascular risk factors before thinking of any other thing. So to make heart failure patients better symptomatically, what do we need? You need to remove that congestion with the aid of your diuretics. So I know that one is readily available. You can use your furosemide. That's the one that is readily available everywhere. For those, some people have torsemide. If you don't want to use furosemide, either oral or IV, intravenous better, because there's also congestion in the GIT that may reduce absorption of drugs and other things. So you want to relieve the congestion, either systemic or pulmonary congestion, with your diuretics. That's number one. Then number two is now look for the etiology. So if it's hypertension, definitely we have to treat hypertension. And here, I want to add this, that when we're choosing medication to use for hypertension for heart failure patients, we have to be careful with the choice of drug. Patients with heart failure are not patients who will use nifedipine to treat their hypertension, because nifedipine is a calcium channel blocker that we know, but it has a negative inotropic effect. It weakens the heart muscle. So we are talking of a heart that is failing, that cannot perform its action. So when you now give them nifedipine, it's a good antihypertensive, but in the setting of heart failure, you have to be careful with your calcium channel blocker as much as possible. So that is a caution, because I know nifedipine is readily available, it is cheap, you can use it to manage hypertension, but once there is heart failure, please remove that and think of other medication. And if you have difficulty, that's part of the reason why you will need to ask for a specialist help in this regard. Then look for other, we talk about ischemic heart disease. You have to, if you don't look for the underlying cause, it may be difficult to get the patient better. Then precipitants, like we said, the commonest precipitant of heart failure in this environment is chest infection generally. So you look for the infection, you treat it. If there is a urinary, chest, anywhere the infection is, it could be, like we said, apart from infection, salt intake. So you have to look into their diet. The dietitian may have to come in. There may be background arrhythmia. Atrial fibrillation is very common in this group of patients. So by the time you do your ECG, that's part of where your ECG will help you. You'll be able to see that, so that you'll be able to identify that, control their heart rate, control the reading. Then look out for other precipitants, electrolyte derangement, anemia, drugs, acute coronary syndrome, you have to look for it and treat it for the patient to get better. Then as you are doing that, you are also looking at all the cardiovascular risk factor. If the patient is diabetic, you have to take care of their blood sugar, take care of the lipid, take care of other comorbidities, that because the fact that patient has heart failure does not mean there cannot be any other problem. Then it's when you do this that you follow up the patient and you see whether the patient needs any other thing apart from the medication you are giving. If the patient has advanced failure, you will need to send to a place where they can do device therapy to assist them. Then heart failure, like you say, is a chronic condition, it's a progressive condition that comes with a lot of financial burden, a lot of psychosocial burden. So they need a lot of support. You need a lot of people to treat this condition. You need the doctors, you need the nurses, you need the dietitian, you need the physiotherapist, you need the social workers to be able to help you, for you to be able to achieve your goal of management. And everything you do will fail if you don't carry the patient along. And actually, this is where everything should start from. Educating the patient, because I said it's a very, very serious condition that will take a whole lot of thing from the patient and from the caregiver. So they have to know what we are dealing with. We have to be able to explain in clear terms what the problem is. Sir, but what we have here is due to this reason and that reason, your heart is not able to do its function because of this and this. And because of that, that is why you are having these symptoms. Your leg is swollen, you have that leg swelling, you have that shortness of breath, you have that difficulty in sleeping flat, so that they understand where you are coming from and you'll be able to tell them, okay, this is our plan. We want to remove as much fluid we can remove. We want to give drugs that will help your heart, that will help to control your blood pressure, and we will do this. Then it is possible that along the line, you may need to get some other things that will help in your treatment. So they have to know the disease nature. When they understand the disease, that is when they will be able to follow your treatment. That is when you have good adherence to treatment. That is when they are going to adhere to also to follow up. Because these are people that, for some people, there may be need for inpatient management. Then you have to continue follow up for life with them. So specialist review will come in. There may be need for support group because, like I said, it is a depressing illness. Because someone that was once active now is grossly limited due to shortness of breath. Some of them are just not able to do virtually anything. They are going to be assisted just climbing from bed, just changing your clothes. Somebody needs to assist you. Because by the time it gets to advanced stage where the patient needs a lot of medication, a lot of support, and nootropic support. So support is needed. Then, like I said, the dietitian has to come in. There may be a lot of changes in lifestyle. Some people may have to change job. I know some people that have to change their bedroom, no longer go upstairs. So they have a lot of things need to come in. And you have to tell them that as we go along, there may be need for procedure, there may be need for coronary angiography, there may be need for device therapy. So all these things the patient needs to know from the beginning, so that the patient will know that we are in for a long ride, we are in for a lot of medication, and unfortunately, many of the recommended medication, they are not cheap. And for now, they're not cheap. They're just coming in the Uperio, the SGLT2 inhibitors. They are a bit expensive. So the patient needs to understand, and both of you have to come down to that level where you both agree there is a good understanding, and both of you can go ahead in the treatment.
I think another thing to add is that
process.
they should also be counseled on the fact that there may be need for frequent admission.
Yes.
Because the patient thinks, okay, I'm taking all my medications, I should be getting better. But there will be times where they have acute decompensation based on these precipitants that we've spoken about. So they may be coming to the hospital. If you have a patient that comes every 3 months, you're noticing that you're admitting the patient again and again and again. It may be quite frustrating for both patients and relatives. So that's another thing we need to consider.
So the informing the patient, explaining well is very, very important, because without that, to succeed in managing patients with heart failure will be difficult, because this condition will not readily go away with just one treatment. So the patient will go, will get better, will come down, because even at our level in cardio care, you will assume that, oh, the patients are, they are well-read, very literate, we follow instruction, we use their drugs. Once you give the drugs, the leg swelling is gone, the breathlessness is better, they stop their medication, and all the symptoms come back, they run back to the hospital. So you need to be able to explain well. It is not just at the primary care level. That education is very important. And this table is just showing what we talked about. Like I said, number one, you want to reduce the symptoms of the patient. That is the first area. So your diuretic comes in, your furosemide comes in here. Here we usually start 20 milligram TDS IV, but depending, you look at the BP of the patient, you look at the degree of edema, and your aim is to reduce the weight of the patient between 0.5 to 1 kg per day. If you have more than this, your diuretic is too much. If you have less than this, it is not enough. But like I said, the dosage is not cast in stone. You have to look at your BP, because like I said, some of these patients will come in advanced level where you can hardly get a BP, or you get a BP of 80 query. For patient like that, number one, you will not be able to manage them at the primary care level. You have to refer them, because before you will be able to give them diuresis, you have to give inotropic support to bring up the BP before you'll be able to reduce their congestion. Then after doing that, you can now be adding other drugs that will take care of all those neurohormonal stuff we talked about, the RAS axis, the sympathetic axis. So that is where all this other medication now comes into play. So your sacubitril, valsartan, your beta blockers, then your mineralocorticoid receptor antagonist, that is spironolactone. That's the common one here. And for patients that cannot take spironolactone or have gynecomastia and whatever, you can give them a eplerenone. Then adding other disease-modifying drugs, the SGLT2, you can now add. So for a patient with heart failure, we must try to make sure that they are on all these drugs, the drugs in 1, 2, 3. For you to successfully treat them, they must be on those drugs. Then it is after using this and the patient is not getting better, then you now start consider them for device therapy. And that's what we are putting, especially for those with reduced ejection fraction, systolic heart failure. They must be on this drug. So our index patient was given digoxin as sent for expert care. None of the important drugs were given to the patient. Digoxin you can use, you will see digitally somewhere here. It is still useful for some group of patients, but your diuretics must be there. Then you must strive to make sure that all these 4 are in play. It may be difficult to use all of them because, like I said, depending on the stage you are getting your patient. Some patients will come at very advanced stage. Like I said, there's a patient on the ward presently now that the BP was 80 query. That patient will most likely not be able to take a beta blocker. may not be able to take angiotensin receptor inhibitor, but at least you can start gradually, and as the patient is getting better, you can be introducing these drugs one after the other. And your goal is to be able to bring in all these important drugs in the management of your patient. So the management of heart failure is just it's not just furosemide alone, because we get referral of patients with only furosemide and with furosemide and nifedipine,
or other antihypertensives,
or furosemide and lisinopril alone. So your treatment is still not yet complete until you have given your patients all the drugs in these classes. Like I said, it may be difficult to start everything at the same time, but your goal is to be able to bring them in one after the other. So, and the next question is, do I need to refer these patients, Dr. Mariam?
It depends on what stage the person comes in. So if it's a newly diagnosed heart failure or worsening, like we said, NYHA 3, 4, maybe the patient was at 1, 2, has now progressed to 3, 4, definitely we would suggest that you refer the patient, or the patient should be managed in an inpatient care. Another thing is, like we said, some patients will present in complete, worsening of states. For example, in cardiogenic shock, we mentioned earlier that the patient has a blood pressure of 80 over something. You can now commence that person on inotropic support in order to be able to give other medication. Now, that may be difficult in a primary setting. So that's the kind of patient that you should also consider referring. Then patients, for example, that have acute MI, so patient came in an acute state, had a heart attack, you've done your ECG, you're seeing your clear ST elevations or non-STEMI, that person should be referred, because and that MI can progress into heart failure. Other things like pulmonary embolism, yes, definitely. When you have a patient with heart failure that have other, you mentioned the MI, then patient develops renal failure, patient develops pulmonary embolism, those are your unstable patients that we would prefer that you refer for inpatient care.
Then when patients, you identify some persistent, maybe patient have some serious arrhythmia, patients in cardiogenic shock, low BP or very high BP,
or severe sepsis.
Those patients, it's advisable they are managed on in the hospital and at the specialist level. If there are other complications, patient is not responding to treatment you are giving at the clinic, then there's challenge. You have challenges in optimizing your diuresis or other medication. You don't know how to bring them in. You're afraid the BP will crash. So for those group of patients, you need to bring in a specialist. You need to refer to a higher center for appropriate care for that patient. And patient might actually ask for a referral for them. So I hope we're putting our questions in the Q&A if you have questions, so that we can take them as we are about to round up with this presentation. So heart failure is a very chronic condition. It's a very severe condition. It's a progressive condition. And like I said, the prognosis is worse than most of the cancer. So we need a good history and physical examination to be able to pick them early at the primary care level. We don't want patients to get to the cardiogenic shock stage. By then, the symptoms and the problem, they are very florid, everybody can see. No, that is not what we want. To be able to identify them at that NYHA 2 and possibly even NYHA 1.
Possibly even to prevent.
And to prevent. Then once we are able to identify, we are able to start guideline-directed medical therapy. our diuretic is there, we can give them beta blocker. By the time it is not every beta blocker. They are not the one that will give atenolol, propranolol. They are not the one who will give difedipine. So we'll be able to choose appropriate medication that will help them in terms of good beta blocker, angiotensin receptor blocker or angiotensin receptor blocker, SGLT2 inhibitor. They are on spironolactone or eplerenone. We are able to adjust their diuretics to get the desired weight loss. So once we're able to do this, and if we have any challenge at any point, you can refer them to specialist care. And like we said, it is not a one-man show. It is a team, multidisciplinary. At a point, the anesthetists will need to see this patient when they are in cardiogenic shock. Because at that point, they are going to be managed in ICU or coronary care units where anesthetists will also be there to help in deciding which inotrope to use at what dose. So you need a lot of people, nurses, dietitian, physiotherapists, social workers. So it's a multidisciplinary approach to management. And when we're able to do this, we'll be able to identify, because like we said, we have more heart failure. Definitely. Because we are getting better drugs, we are picking other conditions that would have killed people, heart failure, heart attack, HIV. So many people will come with HIV-induced cardiomyopathy that will definitely lead to heart failure. So a lot of things. So we're going to get a lot more of patients with heart failure. And so we need to be able to identify the symptoms and signs and able to make appropriate diagnosis. So thank you, and for listening. We appreciate the time you have spent with us. We hope it's not been boring, and we hope we have not been moving a lot of stuff that are not relevant to you. So we'll go to the question and answer. We have some questions here. Let me see.
What are the other calcium blockers like?
Someone asked that, what of other calcium blockers like amlodipine, can it be used for heart failure patients? I want to start by saying, let's start from all those key medications we talked about.
Not our best.
Let's start with those ones. Then, if there is now need, maybe we have a need to control the blood pressure more. If we have started the beta blocker, the patient is on spironolactone, the patient is taking diuretics, the patient is taking either ACE inhibitor or ARB or ANI, and the BP is still not controlled, then we can now be talking of, oh, can amlodipine come? But like a rule of thumb, like I said, we first of all want to avoid calcium channel blocker, especially the dihydropyridine group of calcium channel blocker. All those ones that end with PIN, we want to avoid them. But if we have to use, we may consider amlodipine. But let me say we don't want to use calcium channel blocker as much as possible. And when you need to make this decision, to me, this is part of the reason why you need a specialist advice. Oh, can I give the patient difedipine? Can I give the patient verapamil? Can I give the patient diltiazem? So they will help you, but calcium channel blocker largely. So someone asked, what does decompensated mean in regards to heart failure? Which antihypertensive is safe for treatment of heart failure? Are there patients who survived beyond 5 years? Decompensated means the patient is decompensating. So we have some patients with heart failure that there is stable heart failure. They are on medications, they are doing well. But due to one reason or the other, they have exacerbation of their symptoms. Suddenly the difficulty in breathing
getting worse.
Maybe patient was in NYHA2
has now gone up to 3.
Then suddenly patient now gets to stage 3 or sometimes even 4. So that is decompensation. So for that patient, you have to identify what precipitated that decompensation. Because if you don't identify that precipitant, it will be difficult for you to get the patient better. So you want to know, is there any infection? Did the patient stop his medication? Is there anemia? Is there arrhythmia? Or does the patient have an heart attack? Because in this patient, they may have a heart attack and they may not even have pain. So those are the things you have to look out for to be able to identify the precipitant for the decompensation. So which antihypertensive is safe for patients with heart failure? At least if you look, first of all, consider either an ACE inhibitor, an ARB, or ARNI. So those are the first group you will talk about. Then look at your beta blockers, the ones that are cardioselective. Here we talk of bisoprolol, metoprolol, carvedilol. So before you start thinking of other group of antihypertensive, are there patients who survive beyond 5 years? There are, but they are not many. Like you said, more than half of patients with heart failure will succumb within 5 years. We didn't say all. There are some that will live beyond that period. Okay. I used to think patients with heart failure usually don't present with high blood pressure, but hypotension. Is this the decompensated type? You know, we talked about the causes of heart failure. Hypertension is one, but hypertension is the commonest underlying cause of heart failure in sub-Saharan Africa, including Nigeria. So for some patients, they will come with very high blood pressure or high blood pressure. But for some, the hypertension would have caused that significant damage of the heart, such that by the time they are presenting with heart failure, the blood pressure may just be normal or even very, very low. So you can have all the spectrum, very high, normal, or low. But for all of them, the use of maybe ACE inhibitor, ARB, is not just about controlling the blood pressure. It is about attacking those neurohormonal axis changes that we see. Because we talk about the renin-angiotensin aldosterone axis. For those one, your mineralocorticoid receptor antagonist spironolactone and your ARB or ACE or ARNI must come into that to be able to break that axis. Your beta blocker is working on the sympathetic nervous system. So we are not just giving them just to control the blood pressure. That's why that even the ones that come with normal blood pressure, they will still need to be on those medication. And so for those ones that comes with high blood pressure, so it will serve that purpose too. And if those drugs are not enough, after you have gotten to the maximum tolerable doses for those for the patient, you may now start bringing other blood pressure lowering drugs into the mix. So
the second part of the question is this the decompensated type?
Is this the decompensated type?
Can you have a high blood pressure in acute decompensation?
Yes, you can. Yes. You can have high blood pressure in acute decompensation. It doesn't mean that once the patient has a high blood pressure, the patient can decompensate even in the presence of elevated blood pressure.
Just like our index patient, he came in with a blood pressure of
170,
but it was an acute decompensation at that time. Yes. What steps can we take to prevent heart failure in hypertensive and non-hypertensive patients? So
that is by identifying those risk factors. That's why we need emphasis on the stage A of the American Heart Association classification. We want to patients with hypertension, family history of cardiomyopathy or heart disease, patients with diabetes, patients with lipid dysfunction, patients with valvular problem, obesity. So they have to be looked after. So lifestyle modification, treatment of blood diabetes, treatment of hypertension, regular hospital follow-up. They do their investigations, their echoes, and you follow up. Because we should not forget, and I think we've almost left that out when we talked about the heart failure with preserved ejection fraction. That's those ones with good ejection fraction. They may not have pedal edema. They may not have the only thing they may have is just exercise effort intolerance. When they want to do their whatever, they become tired, they become fatigued, they become breathless. And until you do their echo, you may not even be able, until you do their echo and BNP, you may not be able to know that they have high blood pressure. So people with risk factor, they should go for follow-up, specialist evaluation, echo, ECG, and you may be able to pick them.
Their cardiovascular risk.
Yes. So what are the early signs of heart failure? That's what we've talked about, that they are mostly, the symptoms are mostly non-specific.
Yes.
Fatigue, weakness.
And the signs don't change.
Effort intolerance. So
just get worse.
You just have to be on the lookout. And what we have discovered that people gradually de-escalate their level of activity. So you just say, I used to play ball before, but I just felt, I'm becoming old.
It's always getting
it's
old.
Just because there's shortness, there's limitation, there's shortness of breath with activity. So he starts playing football. Then you say, oh, I feel I'm getting old, not knowing that the heart is gradually getting weak and weaker. So we need to know, okay, I used to walk for my daily morning exercise. I can walk 3-4 meters or whatever, but gradually you start reducing, you start cutting. That person needs to go for a checkup. It may not be sign of old aging. It may be signs of heart failure gradually coming in. Someone asks, how does cardiogenic shock present and how can it be treated, please? Like you said, shock. The first thing is the blood pressure is very. There are other features of heart failure plus evidence of the shock, cardiogenic shock. No, the BP is low. You have cold, clammy extremities and all those other things. So with all other features of heart failure along with them. And this may be the first presentation for some people. So we had a patient that has a very massive heart attack and came in with heart failure with cardiogenic shock. And we had to manage the shock, give her inotropic support. The patient had to be put on intra-aortic balloon pump for him to enter the cath lab to have his angiography done. And to the glory of God, the patient is alive and managing well with the heart failure presently. So I'm doing fine. So the treatment, it requires specialist care in ICU because you need to support the heart at this stage. You need your inotropic support. Like I said, you may need other assisted device to be able to keep the blood pressure up, to save the patient while you're able to give other form of treatment.
What are the most significant signs we can look out for heart failure patients above the age of 65?
Irrespective of what the age is, the symptoms and signs are the same.
Whether it's 20, 30, 60.
So we talk about dyspnea, edema, orthopnea, PND, there may be cough. Then for sign, distended neck vein,
pulmonary
crepitations, third heart sound. So it's similar in almost all age group.
What initial treatment
should be given to a patient with CCM with very low BP before referral? So if it is where you can do inotropic support, that is all you can give. I know we'll be tempted to give fluid. We have to be very careful because, like I said, this patient is already congested, both systemic and pulmonary. So If we give a lot of fluid, we will worsen
the congestion,
the state of the patient. We will worsen the state of the patient, we will worsen the congestion. So the best thing to do for the fast as possible. If you have any inotropic support, you can give dopamine, dobutamine. If it is available, you can give. But IV fluid is not the solution in this case. Can heart failure be prevented in patients with hypertension with good treatment, with good follow-up? It is possible to be able to do that.
What are the
preferred beta blockers in heart failure? I think we mentioned
metoprolol, carvedilol, the ones that are beta selective.
What is the most useful lifestyle change in heart failure? I would say diet. So salt intake, minimize salt intake, good diets. For patients with heart failure, small but frequent meals. Small frequent meals, low salt diets, fruit and vegetables, balanced diets. I would say diet is the most important. Diet is the most important. Then for those with heart failure that have been seen, you have determined their exercise capacity, you can prescribe the level of exercise that they can do. But the most important, I would say, is diets. Diets and diets.
Can atenolol be used as a beta blocker in heart failure?
Can atenolol? It is not advisable to use. It's not advisable. It's not advisable. It's not one of the cardioselective beta blockers that is recommended for use in heart failure. So carvedilol, bisoprolol, metoprolol. Carvedilol is readily available everywhere. It's readily available.
This person is actually mentioning that they work at a tertiary institution, and whenever a patient is referred, the booking date given is 3 months because of the amount of patients that they see. So it's quite difficult for them to have proper follow-up. I think maybe that's what.
For the patient to be quickly seen. So what do we do? That's why I said, at least with the identification of the signs and symptoms, we can start something while the patient is waiting to be seen by specialists. But a lot of other tertiary centers are coming up for the patient that can afford to go to private tertiary institution. They can go, and for those that cannot afford, but at least, like we said, we talked about starting them on diuretics. We can do that. Spironolactone is there. We can do that. We can control their blood pressure. We can look for precipitants, whether it's a chest infection, and do something about them, and encourage them to see the specialist as early as possible, because they just need to be seen. And I'm sure there's no center that will see a very bad heart failure patient that will give them a 3 months appointment. For the case study, why was the hepatomegaly non-tender? Usually what you have is tender hepatomegaly because of the stretch of the capsule of the liver. But this is a patient, he was started on some form of therapy before he got to us. The patient came all the way from Cross River. So he has been through some other hospital before he eventually got to us. So he has been on some form of treatment which has altered some pictures. But usually, typically, what you have is a tender hepatomegaly.
Beta blockers only reserved for those with arrhythmia, or it's a rule of thumb?
Like I said, it is a key part of the treatment for patients with heart failure, because going back to the pathophysiology, we want to block all those pathways, because if you don't block the pathways, the patient will not get well. So the use of beta blocker is not only because of arrhythmia. Whether the patient has arrhythmia or not, patient with heart failure needs to be on the beta blocker. The only caution is when the patient is very congested, like in stage 4, you first of all want to reduce the congestion, make the patient a little bit better before you introduce your beta blocker. But it is almost like a rule of thumb for patients with heart failure.
Can adrenaline be used for inotropic support where dobutamine or dopamine is not available?
If that is what you have,
it's better than nothing.
At least you can use, but the ideal agent to use is dobutamine or dopamine. Then you can also seek for advice of your anesthetist or a critical care person. But if adrenaline is what you use, that is not the best, but it can also be used. The slide will be sent to the email we have used to register. So there's no problem. We will get the slide across to everybody that is registered for the presentation. I have a history of asthma, usually affects me. Sometimes I use Ventolin and I've done a lot. You know, I also play football, so I don't think what could be the possible cause of high lymphocyte count. Okay, we'll answer this question after the presentation. So sorry, we'll take note of that and answer this. Let's look at the charts. If there's anything, I don't think.
There's another question. Okay. Somebody just sent a question.
In lifestyle changes, how much salt should a heart failure patient take? What I want to say is that this is going to be taken on a case-by-case basis. There's no like hard and fast rule that, because you have to look at the level of congestion, you do your electrolyte change, you look at your sodium, you look at everything. But like I said, some may need to stop taking salt, some just a little salt. So there's, like I said, all these things, they are not cast in stone. You see your patients and you decide what is the best for them. So, but salt reduction is general. Mm-hmm. Now, to what extent will be determined by a lot of other factors.
Somebody says some school of thought advise 6 grams of salt per day or less.
This 6 grams of salt is looking at cardiovascular risk factor modification generally. Yeah. That for all of us, it is advisable that we don't take more than 6 grams of salt per day. But now when it comes to heart failure, you need to look further, you may need to restrict further. And that's why I said for some may need to stop salt totally for some time. Some may need to take some control measure of salt. For some people, in extreme case where you have hyponatremia, you may even need to give salt. So it is going to be taken on this case by case. But like I said, the 6 grams of salt is a general prescription for lifestyle modification, for cardiovascular risk factor modification. The same way we prescribe 150 minutes of exercise in a week. Yes. We talk about the salt. We talk about stopping smoking. We talk about
reduction in alcohol.
Reduction in alcohol. So this 6 grams of salt per day is not strictly for patients with heart failure. So we want to appreciate everybody for joining us. We had close to 200 people. Yes. That sat through this lecture, and we hope we've been able to give a bit of value to the time you have spent with us. And what we have tried to do is to just bring down what we need to recognize in patients we think might be having heart failure, to be able to identify the symptoms, to be able to identify the sign, and to be able to take action as soon as possible. And cardio care is here to assist in any form. Your patient with advanced heart failure, we can help out where you need to do your echo, where you need to do echo, where you need to do Holter ECG, where you need to place them on the advanced therapy, whether device therapy. And like for this week, we made the announcements, we sent flyers around, and we are happy that some of our doctors were able to send their patients for device therapy. Patients had CRTD, pacemaker, ICD. We've done for more than, at least this week, we've done more than 20 procedures. Our procedure is still ongoing as we're talking, and that's why Dr. Iseko is not here. At a very subsidized rate for patients, less than 1/10 of what it would have cost normally. So Cardiocare is here to offer our patients this sort of supportive treatment. So when your patient is not getting better on treatment, then you should know that they may be in need of device therapy. So CRTD, that's cardiac synchronization therapy with defibrillation or with pacemaking. Some may need ICD. For some patients, they may have severe bradyarrhythmia that may need pacemaker. So you can send them to us. And like we usually promise, when you send patient to us, we give feedback. We send a report for you to know what we have done. And once your patient is done, either with the procedure your patient comes back to you, you can continue with the treatment of your patient, and we can always discuss with ourselves. And we have our discussion group for ECGs, where whether you have a challenge with ECG, you send it there, you make a first attempt at interpreting it, and people are always there to help to sort out the ECG findings. So we are always here to us. You can easily reach us on our numbers. You will get them as soon as you are getting your slide and your CME. You have our contact there. They are there, so you can always reach us. And by next month, we'll be coming up again with another interesting topic for us to discuss. So we want to thank you, Dr. Mariam, your parting words.
Thank you very much for attending. I hope we've been able to give some, not too much stuff, but more useful information that you can take away with you to your day-to-day practices. So. And
you can continue to send your questions.
Yes.
So we'll answer them on YouTube. The link is there. The link for is in the Q&A, Abby?
Yes.
So the Q&A, you'll see the link for our WhatsApp group so that you can join. Then the lectures, the slide will be sent to you. Then you can also watch each on our YouTube channel. You see all our previous webinars and webinars from other branch of the hospital. So we appreciate you for the time you have given us today, and we hope to see you next time when we have another interesting topic. I wish us all a good, enjoy our weekend, and we'll see you next time. Thank you very much. God bless you.